Thank you. So hi, I'm Jo Preston. As you just heard, I'm a consultant geriatrician. I spend most of my time in clinical practice, but I do have an educational project which I'm going to talk to you about. I thought I'd show you where I work to lighten the day, not near here. I work in Tooting, which this is an article in The Guardian saying that it's akin to Rio de Janeiro. I would say that's an exaggeration, but we do have very good curries. So if you're in London, would like a good cheap curry, then come down to Tooting. And this is where it is. So it's kind of in southwest London. Down. It looks quite far, but it's not. It's about half an hour on the Northern Line down from London Bridge, if anyone's interested. In this talk, I'm going to talk a little bit about what geriatric medicine is, because I appreciate that actually most of you don't work in geriatrics, although ageing is a field that you're interested in. So I thought that might be quite useful, just for a few slides, to talk about what I do and why I do it. And then I was going to talk about some of the positive messages in kind of midlife going into older age. But I thought actually it might be more interesting for me to spend some time talking about how I felt listening to the talks over the last 2 days and what that's made me feel. And one of those things is tension, which is not necessarily a bad thing, but I'll talk through that. And also thinking about how this relates to care staff was the kind of big thing that kind of came to me. And then at the end, I'm going to talk a little bit about my educational project and kind of how that all fits into this. I mean, if you have any questions at any point, just ask me. So frailty is what geriatric medicine is built around. It used to be something we would just look at and say, you look frail. There's been a lot more evidence and research around it over the last sort of 10, 15 years. And so now we have some more definitions around what it is. And so we would say that the state of being frail is distinct from normal ageing. Now, some might argue if you live long enough, you will become frail. And that is not incorrect. But going back to one of the things that Kimberly was saying yesterday about the species has the capability to. You saw the picture outside of the 100-year-old who ran the marathon. Our species has the capability to do that, and so we have to assume that that's normal ageing. So why does that not happen for everybody? So that's the kind of concept of frailty. So it's a distinct clinical entity that has multi-system dysregulation, so affects lots of different areas in the body, leading to a loss of physiological reserve, meaning that you are in a state of increased vulnerability to stressor. So if I get a urinary tract infection, I'm grumpy for a day or so, but I can carry on doing the things I need to do in my life. Whereas somebody who is living with frailty is likely to get confused, have reduced mobility, fall over, and affect them for much, much longer and in much more profound ways. So that's what we talk about when we're talking about people who live with frailty. And there are two main theories around this. One is a phenotype, which Freud put forward, which is a phenotype of 5 things. It's kind of a picture, a snapshot. This is what a frail person looks like. That one's quite difficult to operationalise. So the one that we use a lot more now is Accumulation of Deficits by Rockwood. And he developed a frailty score with some statisticians. And then that has been made a bit more practically useful, and we use something called the Clinical Frailty Score now, which is a series of pictures and descriptors. It's very physically focused. It's not ideal, but it is quite useful for people. Because it's the end of the second day, I thought I might get you to do some immersive theatre on frailty. Not really, but you all stand up for me, just to kind of get you a bit awake as well. So I'm going to try and demonstrate frailty for you. So what I want you to do is to stand and be calm in your mind, but I want you to pick a times table that you find quite difficult. For me, that's the 8 times table, which is very difficult for me. I don't know why. And I want you to start doing it in your head, trying to be calm. And then I want you to cover your ears really tightly. Keep doing your times table. I want you to close your eyes as well. Everybody close their eyes. I want you to stand on one leg. Now hop on that leg. Okay, you can stop now. I'm going to assume that most of you found it much more difficult to concentrate on carrying on with your times table while you were doing that. That's the effect of frailty. If you just close your eyes and do it, not much happens. If you close your ears and happen, not much happens. But with all those things together, it just becomes much, much harder to stay on an even keel. You can all sit down. Thank you. So the way that we kind of operationalise frailty, I guess, or what we do about frailty when we find it and why it's important to find, is because we do this thing called comprehensive geriatric assessment. Now, all of these pictures are, we create them as part of the podcast. They're free infographics that go alongside them to kind of prime the learning before the episode. They're free to download if you want to use them for anything. Comprehensive geriatric assessment is our gold standard care. It's got a really strong evidence base in Cochrane reviews and in multiple systemic reviews as well. It's a process, it's not a tool, it's not a checklist that we sit and go through. It's a lot of people in a multidisciplinary team, all looking at someone in a holistic manner and generating a care plan for them. If we do this for people, people are more likely to be at home or living where they usually live and alive at 6 and 12 months, which, given the very frail group of people that we're doing this for, is actually really impressive. What's more impressive is if we compare that to some of the numbers needed to treat for some common drug therapies. So we know we need to do this for about 17 people to have that outcome for one person. That's neglecting all of the kind of small gains that we might make at home for them as well. If we think about something like taking blood pressure tablets to prevent a heart attack or a stroke, how many people do you think you'd need to give that to? Anyone want to hazard a guess? Higher or lower than 17? It's going to be higher, right, because I'm asking. Yeah. Much higher? Bit higher.
So the outcome is to prolong life for 6 to 12 months?
No, so then if we do comprehensive geriatric assessment, if we perform it for 17 people, one more person will be alive and living at home at 6 and 12 months compared to if we didn't do it.
Okay, now you're asking us how many would you have to medicate with blood pressure
Yeah.
to get that same outcome?
No, to get an outcome of so we treat blood pressure to try and stop people having heart attacks and strokes.
Right.
So lots of people will be on blood pressure tablets. The number needed to treat to prevent one of those, so I'll tell you the answer. 125 people need to take blood pressure medication to prevent one of those people having a heart attack or a stroke, which is huge. And that's something that people are taking all the time. They're like, yeah, sure, fine, it's good for me. You know, this is a much better number needed to treat. So we do. To prevent one of people that wouldn't. So of the people, so it's done at more of a population level. So yes, so if for every 125 people you prevent one of those people who would have gone on to otherwise.
It wouldn't be those people.
It wouldn't be exactly, yeah. It's much more at a population level, yeah. So this was my first sort of reaction to yesterday, really, and thinking about what it is to be a geriatrician. And this is by a colleague of mine called Muna Al-Jawad, who's a geriatrician down in Brighton. And she uses comics as a means to do ethnographic research into practitioners, as practitioner-based research. So she uses it to identify what it is to be a geriatrician. She calls herself Old Person Whisperer. She's not drawn herself in here. But I thought that the power of we were talking yesterday about the power of comics and graphic novels in telling stories and claiming narratives. And part of that autobiographical contract. So what she's done here is to explore what it means to be a geriatrician. You can see here the tensions between the bigger picture and the practicalities. So a cardiologist might look at a 93-year-old and say, oh, no, I'm not going to do anything there. So EF is how hard the heart is pumping. So it's pumping at about 30%. A neurologist might come along and say, oh, get this fancy scan. This is a score that's out of 30. So 12 is quite low, and that's for cognition. So this is saying this person's got dementia probably. Intensive care coming along going, no, thank you very much, they're far too frail. And a geriatrician coming along and saying, well, actually, the main thing is that she can't walk, and actually if we cut her toenails, that might be the thing that makes things better. So she's very interesting and does quite a bit of research. This is roughly what comprehensive geriatric assessment is. It looks different in different settings. It can be done in hospital, it can be done out of hospital, but this is the kind of the breadth of the kind of things that we will look at. We'll go through all the medications, go through their falls, their bone health to try and prevent them from having fractures if they are going to fall in the future. cognition, continence, skin integrity, vision, hearing, pain. So you can see it's a very holistic model that we use. Which brings me to my kind of first, kind of how that brings into sort of some of the tensions that I was feeling listening to lots of these talks. So it was really great to hear all the brilliant work that's being done in such diverse areas. It was really, really interesting. The first thing that struck me was that I was like, oh my goodness, I can't take this back into my daily life. I really want to, but there's just so much of it. There's absolutely so much of it. And if we look at this is what I aim to do on everybody, if I start adding in that bigger picture, like what does that mean for me? And lots of the stories and the passages that were being read, both in their primary form and in the subsequent dissection, are not unfamiliar from the things that I see every day and I think about every day, but I have to kind of narrow down to be able to operationalise what I do. And these were the three things that I wrote down as the tensions that I felt yesterday. One is just literally that scope, that ability to look at that person in front of me in that whole psychological element that we've been talking about quite a lot, in their entirety, within the time I have. Even just at a really practical level, to say, it's really important to me, as you can see from the CGA, it's really broad. I have to know all of these things about people to create a personalised care plan, but actually I have to limit it somewhere. It has to stop, otherwise I just can't do it. And linking that into the kind of ethical principle of justice, I could do that for one person, but it would probably take me 3 days. And there are lots of people who need my service, so how do I balance that? The second was in relation to my role. What is my role? Is my role to delve into those things? Actually, if someone's come to me with knee pain and that's their issue, some people will not want me to go any further than that. Is it my place to start unravelling all of these things or not? One is within the limits of my role. What building am I in? What room do I have? Who are the supporting teams around me that if I identify these things, I can refer them on? So it's really interesting. We're going to hear about loneliness, but if you don't have a team around you that can deal with someone's loneliness, identifying it and bringing it up can sometimes feel worse, to find something you're then not going to do anything about. And actually on a personal level, psychologically as a defence mechanism, I can't take that on for everybody. And I know that sounds depressing, but I kind of have to have a layer at which I will stop and say, no, I can't take on all of these things because I wouldn't function for longer than about a month. Next, I'm going to talk through some of the specific examples that really struck me yesterday and that I thought I could relate to practice. So the first was this description in this great talk, the strain of dementia care as a burden. I could just hear this and see it all over the hospital, in many hospitals that I've worked at. Just because the way they've been organised and set up is not ready for it. It's not that person's fault, it's not these people's fault, but it's just not been designed that way. That inherently parasitical representation of older adults. It's really sad that that's the case, but it is true. That is the narrative that is used. Actually, hospitals wouldn't function if older adults didn't need them. So there is this tension there that I thought was very similar to that. Hospitals need patients. They need to get on and do it. I mean, really, in an ideal world, we would design a hospital for older adults and we'd have a small annex for young, fit people. That's really how they should be designed. It's just that's expensive and it hasn't been done. This is talking about the little one, which I thought was really interesting. I have to be honest, it was really clever and it went over me a little bit because it's just not the sort of area that I'm used to, but I was thinking I would label that BPSD. That's the clinical framework I would put on that. What we're describing is behavioural and psychological symptoms of dementia. And again, that's probably me doing a bit of a psychological distancing. That's what that is. This is how we treat it. That's what we do with this. But again, they were talking about the bid for connection as an act of social contribution and an effort to sustain social interaction. And that is something that on the dementia ward that I worked on recently, we would very much aim to do. And we had our healthcare assistants trained up to be very good at communicating with people with dementia, caring for people with dementia. What I really, really liked, some of the bits I could pull out, and I haven't quite got my head around yet, I haven't finished thinking about them yet, but I really like, is this idea of sharing a common space in liminality as a description of acute care. We are working in an area where we are beyond boundaries and no one really quite knows where we're at. There isn't a clear structure for what we're doing. A lot of geriatric medicine, although comprehensive geriatric assessment has a good evidence base, the individual things don't necessarily. Lots of the evidence that we have is for single organ disease in much younger people. There are very few studies that will look at heart attack and stroke, that will look at lung disease and kidney disease, that will look at even just how those drugs that you're giving people for each of those things affect each other and cross over. So that's one of the things I love about geriatric medicine, is the challenge of that and the creativity that comes with saying, okay, well, what do you need? Let's focus it around that. But it is difficult. But I really liked this description of it being anarchic and nomadic, because it kind of gives it a bit of a power. It gives it a kind of, yeah, this is what we're doing, you know. It's not, you know, oh, we're kind of getting on and no one really appreciates us. It's like we're anarchists. We're doing this in a totally different way, you know. So that's something I want to see if I can convince people back at the hospital. I'm not sure, but they might come with me, they might not. This was really powerful, and I'm not going to talk too much about loneliness because we've got someone who's going to talk specifically about loneliness, but I thought the human right to sustain social interaction is something that I see hugely. I see all the time. And it has huge implications, as I'm sure you're going to hear, for healthcare and healthcare usage. And that's a real tension in daily life, is knowing that someone would be better off if they had more social interaction. Also, the language that was used in there and talking about people in prisons who are people who have committed murder rather than murderers. That's actually a parallel that we have in medicine now, that we try not to call people frail or demented. We try and say this is an older person living with dementia or living with frailty. With that as well, there's some things with the British Geriatric Society were talking about changing their name, and we had a vote recently on whether we should change our name to not be the Geriatric Society anymore. The problem is we don't have a better title, so it was voted against and we kept it. But it is something that it is coming up a lot more. People don't identify with being frail. There was a big study, qualitative study by someone called Caroline Nicholson, who's a nurse, I don't know if any of you have heard of, who did lots of qualitative research with older adults about whether they identified themselves as being frail or not, when objectively as clinicians we would say they definitely are, and they almost universally don't like being called frail or labelled with, but living with frailty they could be on board with. This is a little English language joke that I noticed, that you guys add ality on the end of everything. This has no medical reference, really. I just thought it was funny. And I thought it was probably a sign of intellectuality. Yes, exactly, yeah. But taking that a step further, I wondered if there is a parallel there again with medics using very medical language to make ourselves feel clever and distanced, and whether there's that sort of thing happens in academia as well. And whether where we use research studies as our backup and our crutch, whether the parallel for you guys is using texts to look at something that's quite challenging and ageing. I don't know, you can tell me afterwards what you think. Another thing that made me slightly uncomfortable was the talk on the prefrontal cortex and all the neuroanatomy, which is all very clever. It's very, very interesting, but it reminded me of when I did a stroke job. So we all do lots of subspecialty training while we're doing geriatrics, and when I did stroke, I had this real reductionist, slightly negative, narrow thing, that people would come in with all sorts of weird and wonderful, strange signs. I'd be like, oh, this is so interesting, it's so interesting. You know, it's probably this part of the brain and all of this. And I'd kind of do this weird, like, academic thing where I'm like, oh, it's so interesting. And then afterwards I go, okay, but actually for the patient, I'm going to do a CT head, I'm going to give them aspirin now, and then I'm going to decide which of these two medicines they're going to go on. And then everyone's going to get a statin, and we're going to manage blood pressure in everybody. So it didn't lead to a change in the management all that often. Sometimes it did, but that kind of brought that back for me. The other thing that struck a lot was the Gothic representation, that description. This feels like what I live a lot. That idea of this being a mysterious and supernatural and horrifying thing, that people are aging, that they're living with dementia. and that death is something we have to fight, and people can't die in hospital, and we must not let them die, and we've failed if not, and that it's a mystery exactly. You know, I think as geriatricians we're quite good at accepting that people are towards the end of their life. By definition, that's how they got to us. But you know, within that still we'll all have different slight stances on that, and our peer opinions will be very different, and working in other specialties people may not relate to this quite so much. Also, this idea of researchers and doctors being the hero detectives to defeat is really powerful for me. You know, and sometimes you see that when people come, they're like, you're it, you're going to help me. And I'm like, I'm going to try. But I don't know that I can. And that's a really interesting dynamic that I thought linked in with that quite nicely. This is by no means negative, but there are a couple of things that I thought were sort of missing in some of the narrative. And that's not a criticism, because the aim of this conference was not to identify how this translates into medical practice. But for me, it was looking, as a practitioner, how do I operationalise this? What do I do with it? And I thought it was quite interesting that it wasn't until the middle of the afternoon yesterday that anyone mentioned that, and it was that the psychiatrist said, if someone commits suicide, that has a huge impact on the practitioner themselves. And it was kind of mentioned a little bit in the earlier talk, the first talk that we had in the morning about the arts project in the care home and the impact on some of those things that were coming out on the carers. But I think that's a really important area, and I think it's something that's kind of underrepresented in research, and is probably the key to implementing a lot of this in the future. I think it's quite a messy thing to research, which is probably one of the reasons why. I'm going to show you this. I think it comes back down to our underlying motivations. Why do we work with older adults? What's our motivation there? What keeps us going? If this gets more messy, how do we keep those people working in this area? How do we support them to do that? How do we harness them to be able to do more and more? Which I thought was really interesting. The other thing that I thought about was the triangulation of some of the things that you've talked about. This is kind of a question to you guys, I guess we can talk about afterwards. But, you know, lots of the things that have come up in, we've had a lot of discussions about representation of dementia in texts in particular. Is it routine to triangulate that with, let's say, clinician experiences or research studies or other descriptive elements to kind of say, okay, this is what the literature is saying. Is that true? Does that reflect? Can they provide alternative views backwards and forwards? That was interesting. This is one of my favourite episodes that we did, the psychodynamic approaches. And I think you could not work with older adults and probably understand a lot of it. So I don't get paid if you listen, so it doesn't matter, you know. But it might be interesting, I think, listening to some of these talks for if any of you are interested to have a look at it. And this is a really, really great book written by the Royal College of Psychiatrists about the culture of healthcare, about the way that we are set up, the way that we are designed. You have to make choices about what you're going to deliver, how you're going to deliver it. An example of that is when I was a second-year registrar and I had a patient who really, really, really needed an urgent dose of steroid. And I said to the nurse, this person really needs some steroid. And I came back half an hour later and she was just so busy she hadn't managed to do it. And I was like, this is really urgent. She's like, I know, but that woman's been waiting to be fed for half an hour and I need to get to her. She's so malnourished. And those are the kind of tensions that people are actually dealing with. And so this kind of goes into that. It's not that if that person had deteriorated because she hadn't had her steroid, there would have been a lot of criticism. Why didn't you do this? The doctor told you to do it, da da da. Actually, she was trying her hardest. She was trying her best. She just had so many other things going on. And this book goes into that in a really, really clever way. So on to my project, the podcast project that I've made. I think my motivation for doing this is as a way to tackle that, as a way to try and support staff who are working with older adults. They are everywhere. Unless you work in paediatrics or purely obstetrics, you are going to look after older adults. There isn't a lot of postgraduate education around. If you work in surgery, you will be working with older adults. But the little study budget that you have and the time that you are not going to go on a geriatrics course unless you're already interested, in which case we don't need to try and reach you. So that's why we decided to try and make a podcast. Well, we did make a podcast because it's accessible anywhere, it's free, it's open access, and people can listen to it on the way to work. We're funded by Health Education England, and it's aimed at anyone that's working with older adults. It does assume some healthcare knowledge, but we've got quite a lot of people listening who are social workers. We've got quite a few people, random people that tell us on Twitter, a couple of porters who have found it quite useful to kind of understand what they're doing and how and why. So as I said, we make these infographics to go with them. We create show notes with all the references for everything that we're doing. So it's very, we think we've got quite a lot of educational rigour around it. We have learning objectives, things like that. And they're all kind of based loosely around the comprehensive geriatric assessment. This was our first one, and then all of the others are delving into an aspect of it in more detail. We've got about 50 so far. I'm also very conscious this is probably like the second graph of the whole thing, which is very unusual for me being at a conference. It's a bit weird to look at. Along the end is the episodes we've made. We've made 50 now, and we're making our second 10 now. They kind of go backwards. These are the newest, and these are the oldest. And each colour is a time point where we looked at how many people had downloaded the episodes. So what we're seeing is that, this bottom line is the most recent one. No, the first time that we looked. So the first time we looked, we'd had that many people listen. We're now up to having that first episode that we put out, about 4,500 people have downloaded it, which we're really, really proud of. What we're noticing is that people go back to the beginning and then work their way through the episodes. But also you can see that some episodes are preferred over others. Typically things like continence people don't want to listen to because they don't want to address it. And this one down here is one that we did from a conference, so they tend to be a little bit less popular. And this is kind of a running tally, so I checked this yesterday. So in total, for the 50 episodes, we've had about 86,000 downloads. So we're quite proud of that. So it's my last couple of slides now. This is kind of coming back to why this all matters. Why do we need to educate people? This is a difficult area to work in. As you've demonstrated with lots of the talks that we've given, there's a lot of tension in the writing about this because it's difficult. And this is another cartoon by Muna about compassion and being a practitioner with compassion. So I'll just give you a minute to read it. Shall I read it?
Yes.
So the first top one says, there's a myth that acting with compassion is easy. And in a brain bubble she says, and sometimes it does come naturally. Here's a cup of tea, Mrs. Jones. Oh, thank you, doctor. But really it's not. And she's saying, I'd like to ask for forgiveness from my fellow humans for my lack of compassion, with an article from the Daily Mail underneath. And then it says, I'm sorry to the man who came in and had deliberately self-harmed. And she said, oh, what have you done this time? Sorry to the people that I've walked past when she's busy and trying to get somewhere and people are calling. I'm sorry to the family that I gave false hope to. When she knew that something was wrong, she's saying, don't worry, he'll be fine. I'm sorry to the woman that I kept treating even though I knew it was futile. She's saying, ouch, that hurts. And she's saying, just keep still, I need to take a blood test. I'm sorry to the colleague that I spoke to sharply. Look, I'm really busy. Couldn't you have just sent that person home from A&E? And oh, God, I'm sorry. So how do I atone? My options to say 3 Hail Marys, to give up and burn out. 3, to ignore the problem. 4, blame the nurses. 5, blame the patients. 6, blame the media. And 7, accept that it's hard and support each other and keep trying anyway. So last year, me and Muna and Ian, who I make the podcast with, set up a fringe at the BGS, which is the British Geriatric Society conference. They have a conference twice a year, and they were very nice, and they trusted us enough to let us try this. And it went really, really well. There's a real thirst for this. The things that you're talking about, there's a real thirst for, because it gives context to what we're doing, and it helps us to balance and keep some compassion with what we're doing. You know, we are a profession that is built from, you know, science and medical research, but actually we're all pragmatists. We're all generally quite nice people who like looking after older adults. And actually the scientific medical model doesn't really support us very well. So we ran this last year. It went really well. We had loads of people inputting. We had a flash choir. We had a book club. We had people submit their own art to display in relation to their work. And we're going to run it again this year. So if you're interested in being involved in anything like that, then please do let me know, because we need things like this. Okay, that's it.